time for the disease intervention specialist to hopefully interview me, who now has syphilis, and find out all my partners and get or Barbie and Ken in to get treated before they, infect anyone else. But this is a very simplistic line diagram. This is what it really looks like. And if you have the chance, there's a beautiful review by Khalil Ghanem in the New England Journal in 2020 that goes over the natural history of syphilis. So you can see it's not just a straight line. Some people after 9 to 90 days have that primary infection at the site of inoculation. And that can be in the throat, in the rectum, on the penis, in the vagina, wherever. And they go from the primary stage, which they may or may not, see. They can go into latency. Early latent is within 1 year of that infamous secretion exchange event, or they can go into secondary syphilis. And eventually everyone will go into late syphilis, and they can either then develop lifelong latency where the person lives with the spirochete and the spirochete lives with the person, and it's no harm, no foul. They die together. Or it can go on to end stage tertiary syphilis damage. Now, sexual transmission is pretty efficient, and it really only occurs in the early stages, like primary, secondary is the most efficient stages for transmitting this disease. So the risk of infection after one exposure is about 40%. As I said, the index person who has syphilis and is engaging in sex with other people is most contagious during the primary and secondary stage, and then less so in early latent, which is we call in the United States less than 1 year duration. Now, vertical transmission, however, can occur at any stage of syphilis. So the mom can give this to the fetus at any stage, but it is most efficient transmission during the early stages, primary and secondary, about 80%, and then at 10% in the late stages. Now, rarely can it be transmitted through blood transfusions and organ transplantations, but we screen aggressively for this. So we really don't see much, if any, of this now. Okay, I have to wait, hold on. All right, now let's talk about primary syphilis, get everybody renew what it looks like if you're lucky enough to see this. The chancre appears, as I said, 2 to 3 weeks, 3 to 90 days after exposure. And when you look at the exact number, it vacillates, but 9 to 90 days is a nice thing to remember. It's local lesion at the site of inoculation where you have sex. It's typically, if it reads the textbook, it's typically painless, it's indurated, it has a very clean base. So it kind of feels, if you were to palpate the lesion, it would feel like the edge of an Oxford button on a shirt or a rolled up condom. Now that's if it reads the textbook. But 40% lesions are multiple. As you can see, I believe down here in the lower right-hand corner, there are multiple lesions, and they can be painful without herpes being present. So, when I say this is a typical presentation, syphilis laughs at that sentence. It can look like anything. You can also have regional adenopathy, which is classically rubbery and painless and bilateral. Here's some brilliant extragenital primary syphilis lesions. These are beautiful lesions. Here's one on the left, right there in the where the lips meet. Beautiful lesion on the tongue, on the lip. And as you all know, oral sex is sex, and this is how you get it. Now, if you march into secondary syphilis, which is the spirochetemic phase, meaning that the spirochetes have spilled over into the blood in large numbers and they can go anywhere, you can have a presentation of almost anything. Look, it can involve the skin, which rashes, and I'm going to show you these mucus patches, condyloma lobata. It can involve the eye. Any chamber of the eye can be involved. It can involve the nervous system with meningitis or even asymptomatic or symptomatic meningoencephalitis. It can present as a stroke. Lungs are involved. They can have a pneumonitis. We have seen cases of this in the past, I guess, like 5 years. You can get arthralgias and arthritis, and it can feel like a really bad virus, but it's a really bad spirochete. The kidneys can be involved, and so can the digestive tract. We've had case reports of syphilis presenting as hepatitis and gastritis, even. So, syphilis is the great imitator. You have to remember that and have a high index of suspicion. Well, now here's some early secondary syphilis rashes. The one on the left is not as dramatic as the one on the right. So, I mean, it can be either or. Sometimes you have to pull the person over into the natural light to see if they have a rash. It can be that subtle. It is macular at first, but that then develops into a papular eruption. Now, the macular rash usually doesn't involve the face. It usually is not itchy, but some people see a rash and they scratch. And if you were to look for spirochetes in those macular lesions, you would not see them on dark field examination. Then it evolves into this papular eruption, which can involve the entire trunk and the extremities, and particularly the palms and the soles. And it usually is scaly, but it can be smooth, follicular, pustular. Now, the rash of secondary syphilis can look like anything. So when we oftentimes get fooled when people come in and they're HIV infected and they have a rash, and you think, oh, this is related to, the HIV infection. It could be syphilis. Same thing with pregnancy. Pregnant women comes in with rashes. They do get rashes. You think, oh, this is related to pregnancy. No, I want you to be suspicious these days and send off a blood test for syphilis. Now, here are the gorgeous secondary syphilitic rash pictures on the palms and the soles. You can see there's flaky consistency. And this gentleman here in the left-hand corner, you can have it on the palms. It crosses the lifelines, if you will, here, which other, dermatitides don't. They respect the lifelines. These are lifelines that Sister Sarah reads your fortune. She can tell you to get down to the clinic and you'll live a long time to get your syphilis treated. And look on the soles of the feet. Now, people can have only the soles or only the palms involved, so you have to look at both. Here are mucus patches. You got to look on the mucosal surface. They can be subtle, they're flat, they can be in the mouth, down the pharynx, and in the genital area. And you can see here on the left-hand side, these are kind of subtle, whereas this is dramatic. And here in the intertriginous area between the vagina and the rectum, you can see these patches. Now, you can also have what's called condylomata lata, and not to be confused with condyloma acuminata, which is HPV lesions. Human papillomavirus are warts, and they're, they can look like this, but they are dry, dead, heaped up skin. These lesions are moist, and they happen not when where the person has sexual contact, but in warm intertriginous areas. So classically in the rectal folds, along the vulva here. You can have them between the scrotum and the thigh. They are teeming with spirochetes. So if the person has not slathered it with an antibacterial cream, you can take the oozing, the exudate from the oozing lesions and look at it under dark microscopy, dark field, if you're so lucky to have it. And you can see the spirochetes swimming about. Now, why do we use dark field microscopy? Because these spirochetes are so thin, you cannot see them on a light microscope. So you have to bounce light off them to see them. And you can have patchy alopecia, losing your hair in patches, because the spirochetes, when they get in the blood, they get stuck in the little arterioles that feed the hair cells and consequently cut off the supply. nutrient supply to the hair follicles, and they fall out, they die and fall out, but it comes back after treatment. So let's look at why we're why we're concerned about this these days. You know, before the turn of the century, I can't believe we're saying that, but in 1999, we were really happy. We thought syphilis rates, look at this figure on the right. Syphilis rates had gone down dramatically. And we were talking about syphilis elimination efforts. And we had a national plan to eliminate syphilis. And again, the treponemen laughed at us. So what happened? Where are we now? Well, yeah, it started to go up first among men who have sex with men primarily. You know, it had to do with highly active antiretroviral therapy. People were getting great drugs. They were immunosuppressed from their HIV. They felt better. They were not as transmissible of the HIV, and so consequently, sexual encounters increased. Okay. The male to female ratio in the beginning of the turn of the century here in the first couple decades was mostly males, but when we got to around 2015, females started to get a lot of syphilis and the rates went up. So the male to female ratio went down, and here's where we are. During 2020 to 2021, the rate of reported total syphilis increased 31.7%. Okay. Now, there's two distinct epidemics going on in the United States right now. One is among men who have sex with men. You can see the CDC slides here showing the primary and secondary syphilis rates. And if you look at MSM, increasing rates since 2001, and between 2017 and 2021, there was a 74% increase. 45% of these cases were among men who were also living with HIV. And nearly 30% were reinfected or are reinfected in the 3 to 6 month time frame after they've been adequately treated. So here down in the left-hand corner is supposition graph that says, you know, what happened, Stonewall riots, gay liberation, but then HIV, everyone start, you know, practicing safe sex or not having partners, and the rates of syphilis per 100,000 population went down, and then we had HAART, and now we have PrEP, so rates are going up. Now, when you look at the lower right-hand corner, I just want to say that this is what the CDC knows from what's reported to them. And if you look at the cases by sex, sex of the partner, and HIV status, you see a big chunk, like 31%, occur in men who have sex with men only. And then you have about 21% in men who have sex with women only. But here's what you have: men with unknown sexes, sex partners. That's a big chunk. So we don't know if they're men who have sex with women only, with men and women, with men only. You know what I'm saying? So the CDC can predict what's happening based on the data that we give them. So when you're filling this out or you're reporting it, try to get a good snapshot of what's happening with the patient in front of you. What's going on with them? Who do they have sex with? Who, what, when, where, how? And it helps us figure out, where do we need to intervene? Now, here's the heterosexual epidemic. During 2020 to 21, the primary and secondary syphilis rates, again, primary and secondary most contagious, among women increased 55%. And the rate among men who only have sex with women increased 23%. Now, if you take the last 5 years and you look at primary and secondary syphilis rates among women, it increased 217.4%. When do you see that number? I mean, that is dramatic. It's stunning. And the increase among men who have sex only with women was 50%. Now, consequently, when you have increases in syphilis among women, you're going to see it in congenital syphilis. And it was inevitable that the rate of congenital syphilis increased. And from 20 to 21, the number of cases increased 32%, with a 52% concurrent increase in the primary and secondary syphilis among women. And that's in the reproductive ages, 15 to 44. During 2012, however, broadened that scope of looking at these rates. From 2012 to 21, the number of congenital syphilis cases increased almost 800%, 755%. I mean, that's dramatic. So we are indeed concerned. This is very scary. And this congenital syphilis truly is a failure of our public health, because we should be able to diagnose it early, treat it before there is transmission. So this is a call to action. This is a wake-up call. Is syphilis around? Yeah, it is. It is. So ask the person that you're seeing about, who they're having sex with, do they know, their risks, and try to figure out, are they at risk for syphilis? If they have no signs or symptoms of syphilis that you can see, then screen them, send off a blood test if they have risky behavior. Now, sometimes people say, what is risky behavior? Well, you're talking to the person and hopefully you can riddle that out. If they look like they have any sort of lesions of primary, secondary syphilis or any presentation consistent with syphilis, then test, send off that test. Treat effectively, and you're going to hear about this on the next slide, but then most importantly, intervene, talk to them, get in touch with the disease intervention specialist, have somebody figure out who their partners were, and we get and finish I've been waiting for someone to come back.
Hi, Anne. You cut off at the end a little bit, but I think we all got your call to action. And thank you so much for such a great presentation. I just want to highlight two things. One, we will have a Q&A session at the end, a very short one, where I see y'all are putting some questions in the chat. So we'll be able to answer some of those at the end. And I am providing speaker bios in our chat as well to cut down on me speaking and giving our true speakers more time to go over their presentations. And with that, I want to turn it over to Dr. Irene Stafford. So here you go. You are still muted, Irene.
Unmute myself. There we go. Let me get my slideshow started. So again, thank you so much for this opportunity. It's really fantastic to be here today to talk about perinatal syphilis. I know Dr. Anna went into it a little bit, but I'm super excited to give you a little bit more detail about what's happening on the perinatal front. So we saw this slide. We know that congenital syphilis is on the rise. Obviously, the black line is reproductive age women, and the blue line is our congenital syphilis cases as of 2021. That many cases of congenital syphilis, 2,855, and I think preliminary numbers, and I'm sure you all can speak to this better, is over 3,000 cases of congenital syphilis in the United States. So in my neck of the woods, we've had some serious issues with congenital syphilis. In 2019, actually, data showed that we had a 250% increase in congenital syphilis cases. And I do want to point out the second bullet point here, which is really just disheartening to me, is that 100% of the fetal deaths that were happening in Houston were among Black and Hispanic patients, illustrating the disparities in care. So this unfortunately came out it came out very recently. So in July, just a few months ago, we saw that in Houston, in Harris County, we had a significant 9-fold increase in congenital syphilis in Houston and Harris County. And I can attest to this because we do have a perinatal syphilis clinic where we are seeing unbelievable amounts of perinatal syphilis, of mothers that are pregnant and have syphilis infection. So this is just an interesting heat map that was given to me by the Houston Health Department, and the yellow zones are the hotbeds of syphilis infection, where we can see right here in the medical center where I work, we have probably some of the highest rates of syphilis. This is all adults, by the way, and you can also see in some of the northern counties where really they're clinic deserts, there's a significant number of syphilis cases, and in the southwest region of Houston, where we do have a pretty different, a pretty unique population of there is actually some transactional sex workers in that community. So I was curious, why is this happening? Is it have to do with COVID? You know, what is affecting our Harris Health population? What's going on in Texas and Houston? So I really took a deep dive in looking at our patient population in Houston and looked between 2019 and 21 to see if any, what the individual composite rates were of STI in Harris Health. And then, of course, look at any adverse maternal and neonatal outcomes with these STI infections. And really another subgroup looking at the rates of individual and composite STI according to COVID status. So in women who were COVID negative and women who were COVID positive, what did that look like? So this is what we found. And I think this is astonishing. And it was, fortunately published for the public to see that in pre-COVID to during COVID, our syphilis rates were the only STI that significantly changed. You could see there that we were at 1.5%, okay, of our pregnant population in Harris County that we screen and take care of at UT and Baylor. Okay, 50% of these patients were other institutions. We saw a significant increased risk or increased rate of syphilis infections in pregnant women. And look here, the adjusted relative risk of adverse maternal and neonatal outcomes, not surprisingly, was significant. So this is among COVID positive patients. So this is between COVID negative and COVID positive patients during the pandemic up to this time. And what we saw was, again, look at that number. I mean, granted, it's a low number of people screened, but it's a good year and a half worth of data that we saw the syphilis rates in pregnant patients that had COVID were significantly higher. And again, significant risks of adverse maternal and neonatal outcomes. So this is this is just really the biggest disappointment is how hard syphilis diagnosis really is. And as Dr. Anna pointed out, you can see that syphilis infection takes time. You have this first serologic response, and then you have the treponemal response, and then you have the non-treponemal response. And to the average physician, obstetrician, gynecologist, this is hard. This is like super hard. I get called every other day, and I'm sure everybody here on this call can attest to this, about titers. What do they mean? I just want to point out that the FTABS or the TPPA, which I strongly advise TPPA or TPA over the FTABS, can remain positive for life. Okay, this doesn't really tell you much. It just tells you that the patient has past or present syphilis. And then, of course, the RPR, even if a patient is treated, still can go down a little bit. Okay, we just want that 4-fold decrease in patients who are treated for syphilis. Okay, so as you see here, primary, secondary, this takes years, months to years. But again, in that early phases of syphilis, as we looked at the stages, they come and they go. Sometimes patients don't even know that they have symptoms. So good news about pregnancy, at least we'd have this going for us, that the diagnosis is the same as adult syphilis diagnosis. So basically, the reverse of the traditional screening algorithm and exam, of course, to clinically stage the patient. All right. Obviously, we know that the non-TREP is recommended for determining serologic activity to make sure we had response. Okay. And again, a ton of these patients stay positive for life, and thank God for our health departments and our regional supporters to get us through this, walk us through if this patient has past or present syphilis. So obviously, this is what the testing algorithms look like. Most of us have gone to the reverse. However, there's still some that start with the RPR. And honestly, I don't really have a personal preference. I do think that the reverse is a little more sensitive than the traditional. We're having some discordant RPR problems. And I'm sure that everybody feels that way too. So we had some beautiful pictures of primary syphilis, secondary syphilis. Again, these do not change because a patient is pregnant. But as Dr. had pointed out, these rashes in pregnancy are so common, you know, between pups and urticaria, that sometimes we don't know that it's in fact syphilis. And as we talked about earlier, this is when we have the highest congenital infection rate. This bacteria is so transmissible that in early infection with syphilis, there's a 70% chance that this will be transmitted to the fetus and cause congenital infection. So obviously early latent, we still have a pretty high risk because that's still considered early infection, and latent or unknown duration, there still is a risk, about 15% that patients who present to care for late latent will have a baby that has congenital syphilis. Okay. So more good news is that the treatment is the same. Okay, we do benzathine penicillin. Well, actually, I stand corrected because now we have a penicillin shortage, and we're trying to move to doxycycline for non-pregnant patients and their newborns. However, in general, the treatment is benzathine penicillin for pregnant patients. Okay, depends on the stage and the clinical manifestations, just like what we know. All right. We do need to see that maternal non-treponemal titer decreases 4-fold over 6 to 12 months. Okay, treatment depending on their stage. We hope that we can get that 4-fold decrease, especially for early infection, in that first 6 to 12 months. However, this is why I'm turning prematurely gray, is because we don't always have 6 to 12 months. Sometimes these patients present at 28, 32 weeks, and we're at 1 to 32. We give them treatment. Hopefully they'll drop before they deliver before 37 weeks. Again, a clinical conundrum indeed. So the CDC recommends that we check these titers in pregnant women every 8 weeks. Okay, closer if indicated. If you have a patient who says, you know what, Dr. Stafford, I'm having this rash. My partner wasn't treated. I feel like I know you treated me, but I'm concerned. Absolutely, you can recheck in 2 weeks. Here at my institution, we're checking every 4 to 6 because we have an outbreak, and we do have a lot of partners who unfortunately are just not being compliant with treatment. So again, the big rule, and this is probably the most important take home for pregnant women, pregnant individuals, is that we cannot exceed 9 days between treatment for latent infection, or else the poor patient has to start over again. Okay. So again, 4 to 6 weeks, CDC says every 8, but again, there's always that, if you're concerned about re-exposure, please retest. Okay. So the JH reaction is real. It happens in pregnant women. It happens in non-pregnant people. I just want to point out the fact that babies, the fetuses that have congenital syphilis, can also experience the JH. They can have fetal decelerations. They can have bradycardia on their strip that would actually prompt delivery. Okay, so I just want to make it clear that babies that have any evidence of congenital syphilis on ultrasound probably should be obsed in the hospital when they get their when the mothers get their penicillin. A little supportive care with oxygen, fluids, and Tylenol usually gets those mothers and those fetuses over the hump. Okay. So let's talk a little bit about fetal infection super quickly. This is my life. I live to find congenital syphilis, to treat these patients because of this fact, okay, that this very pathogenic bacteria causes premature birth, miscarriage, stillbirth, high drops, and perinatal death in 30 to 40% of babies of mothers that are untreated. Okay. So it crosses the placenta anytime it feels like it. It's hematologic, it's transplacental, all stages, all trimesters. Excellent work from Pablo Sanchez in the Parkland days show that we could even see T. pallidum in abortuses of 6 weeks, 6 to 8 weeks. And we talked about that the transmissibility rate is so darn high. The biggest problem that we have with syphilis diagnosis and pregnancy is we really, unless we have a rash or a lesion, and even in those cases, we don't know if it's 9 weeks. We don't know if it's been the last 3 weeks. It's often difficult to know that temporal relationship between infection and evidence of congenital syphilis. So it causes mass inflammation to all the organ systems, almost like a SIRS kind of response. Affects the spleen, the liver, the placenta, any organ for real. It does seem to have a predilection for the hematopoietic cell line, likes to eat the red cells and cause fetal anemia. So again, you might see it go into the placenta and the fetal liver where those little red cells are being made. Okay. This is an elegant slide from Dr. Lisa Ollier, who talked about how the infection kind of progresses in the fetus, starting from the liver to the placenta to fetal reactivity and so on. Okay. And again, the last stages there when you're getting really infected is this evidence of fetal high drops, which is evident there by sonographic ascites. So how do we know if a fetus has it? We look for it. We look for it with ultrasound to the best of our ability, okay? So what do we look for? We look for a big placenta, we look for a big liver, and we look for what we call elevated middle cerebral artery velocities, where we detect for fetal anemia, okay? So we know that this baby is infected if it has any one of these markers, okay? This is just a sagittal view of a fetal liver. So you can see that we're measuring the liver length. This is a fetus that was in fact infected. This is just an example of what we look at on maternal fetal medicine side. So this is the middle cerebral artery velocity. It tells me, is this fetus anemic from congenital syphilis? So again, the specialized role of fetal ultrasound can't be understated. I mean, we're doing this study here. We're over halfway through, looking to see if there's anything else at all that we can do to detect whether or not a fetus has congenital syphilis. Placenta is great if you have a special lab, if you have those special stains. Dr. Sheffield, who is my mentor of all mentors for congenital syphilis, showed that it's super sensitive, especially for IUFDs. Unfortunately, we're not quite there for molecular testing yet, but I'll tell you one thing, we're all working on it, and we're working on it hard. So diagnosis at birth is even more confusing because none of our serologic tests are that sensitive. The PCRs are not that sensitive. The treponemos, just like adults, can be positive for a long time, or they could even be falsely negative in early infection. So given this, what do we have for hematologic analyses for the newborn at risk? We have the non-TREP. The non-TREP is only 14% sensitive. The reason why it's not that sensitive is because it could be maternal IgG transfer, okay? So what do we do with it? We just figure it out and record it and hope to God that it's not higher than the mother's. So how do we know if a baby that's been exposed to syphilis has congenital syphilis and should be treated? We look at maternal treatment history. If it starts 30 days before delivery and the titer doesn't go up on the mom, then that's pretty good. That means that likely this baby doesn't have congenital syphilis. Is there any antenatal sonographic findings that we saw? That might prompt a workup, even if it's 30 days. Any newborn signs or symptoms, that's a symptomatic baby, that's a case. Any bone or lab abnormalities, it's a case. And again, for that non-TREP, unless it's a 4-fold higher than the mother's, we just record it. We just record it and hope it goes down over time. Okay. So again, the symptomatic newborn, pretty straightforward. Remember, really important that 60% of babies that are symptomatic at birth have neurosyphilis. But what about the asymptomatic newborn? I'm going to just make the very important point, okay, that 60% of infected newborns, like treponema positive babies, are asymptomatic at birth, okay, regardless of the titers. The problem is we don't know whether or not a baby is truly infected or not when they're asymptomatic and they have no abnormalities and mom's been treated. Unfortunately, there's still babies that we do everything right and they do in fact have congenital syphilis. So again, there's still some babies that are being discharged, even if we've treated mom, even if we've evaluated baby that was supposedly an asymptomatic non-case, they still come back with evidence of congenital syphilis. Again, there's really not a ton of program and support to actually follow these babies up to 15 months of age. The reason why we need to do that is to make sure those non-treponemal titers drop. So why are we having such a problem with follow-up? In Houston, and maybe it's better in other regions, we only have 37% follow-up of babies. Only 37% of mother-baby dyads follow up to make sure that they have absence of infection, that titer goes down to 0 or 1 to 2. So what factors really matter for this follow-up is nothing to do with the obstetrical or infectious related morbidity. It has nothing to do about whether or not the baby was infected or went to NICU. It has everything to do with social, economic, and demographic factors. We look here and we see non-English speaking. We see here that no prenatal care. We see here that anybody who had a psychiatric diagnosis are less likely to follow up and get appropriate titer follow-up. This is just a devastating picture of a baby with congenital syphilis. So penicillin allergic patients we can still do skin testing to see if they are in fact penicillin allergic. I do want to make the point that 85% of people do grow out an allergy. They grow it every year. It's a 1% drop in penicillin allergy. If a patient can get skin tested, fantastic. If you have a super low risk allergy, you can go ahead and bring them into the hospital, especially for pregnant women where skin testing may not be as popular. But you can, in fact, do safe skin testing in pregnancy outpatient. Okay, if they're negative, you can do 250 milligrams of amoxicillin and then go ahead and give them the IM penicillin. Okay, so for me, if they're low risk, if they had a GI intolerance, a headache, I honestly don't even do the skin testing. I just bring them in and give them an oral challenge. If they're fine and they tolerate that 250, I send them home, okay, at 30 minutes after the benzathine penicillin dose. This is just an elegant oral desensitization protocol by Dr. Wendell. It's really quite easy to do. It takes about 4 hours, okay? So again, if you have a severe allergy, the person's like a good historian, they're like, oh, I actually have interstitial nephritis or hemolytic anemia. Okay, that person needs to come in and get desensitized. No skin test, and no amox challenge, okay? So my cry today is, number one, please, if you have a baby with a viable fetus, even 18, 19 weeks, please let us take a look at the baby and see if the baby has any evidence of congenital syphilis. If they're viable, please consider talking to your MFM obstetrician about getting them seen, getting them in the hospital so that we can make sure babies do okay with it. Okay, again, the ultrasound should not halt your treatment. If you're 28 weeks, you have no MFM, you have no OB, and you have a pregnant patient, go ahead and start a treatment. Okay, don't delay just because of the desire for us to have an ultrasound of that fetus, but please confirm viability. So this is my call to action. Okay, we need to improve our screening practices. We are all over the place. In Texas, it's 3 times during the pregnancy. In some states, it's once. Okay, it's confusing for doctors who go from, say, Mississippi to Wisconsin to Texas. I mean, sometimes they miss the memo. Honestly, a best practice alert, we instituted a best practice alert at Harris Health, and wow, it made an enormous difference, a significant difference. In fact, 65% increase in correct testing timing for people in Houston that were pregnant. And of course, I think this is probably really the most important thing, especially for high prevalence settings, is opt out in the ED or any non-traditional setting. No closed doors, all open doors for pregnant patients. Please consider opt-out testing in any setting. Thank you so much.
Thank you so much, Dr. Stafford. I will add that there are a lot of questions for you in the chat or in the Q&A that you can also check out. But a reminder, we will have a short Q&A session at the end. And with this, I now turn our conversation over to Dr. Kimberly Stanford, and I hand it over to you.
All right, great. Thank you. So that was a perfect setup. Thank you for that, because you've already introduced exactly what I'm going to be talking about. So I'm an emergency physician, and this is my disclosure. And I always kind of start this by talking about why in the world am I even here? Because this is not something that we normally think of as a problem of the emergency department. It's not an emergency. And so, usually I have to kind of explain why syphilis is a problem, but the 2 previous speakers did an amazing job of that. So now you're convinced of that. And now I want to convince you that we really need to focus on the emergency department as one of the most important places to stop this epidemic. And to do that, I'm going to show you a little bit of data about emergency departments in general, and then I'm going to tell you a little bit about what we've done in our own ED in the south side of Chicago, which is a very high needs population. So this is national data. This is a little old, but I couldn't find anything more recent. But this is looking at healthcare utilization across the U.S. And as of 2010, when this was published, almost half of medical care contacts in the U.S. are in the emergency department. We know that this disproportionately represents Medicare and Medicaid beneficiaries, racial and ethnic minorities, women. So the kind of populations that you would imagine are traditionally having less access to outpatient care, and also the ones that we do see the higher numbers of syphilis in. 140 million ED visits happened in the US in 2021. So we know people are coming to the ED. We can see here, this red line is the ED. We know there's more going to the ED really than anywhere else in the healthcare system. So this is where people are. And I like this one too. This shows ED visits within the last 12 months across several age groups over the past 20 or so years. And you can see this young age group here, 18 to 44, which is particularly of interest when we're talking about congenital syphilis. More than 20% of them had at least one ED visit in the last 12 months. And pretty much in every year throughout this whole period of time. So again, we know maybe people are utilizing the ED a little, maybe they're using it a lot, but they're all using it. And that's where people go, even if they don't access outpatient care. And why are they not accessing outpatient care? It's obviously a very complicated issue. But this graph shows the percent of patients that reported an identified source of primary care. And this is how it's changed from 2002 to 2015. And you can see in every single age group, the number of people who reported an identified source of primary care went down over that period of time. And particularly in that young age group, again, thinking about the folks who are going to be kind of our target group for congenital syphilis prevention, big drops in the number who had a primary care source. And we were curious too, where are they going for their STI care? Where are they getting STI diagnoses? And so this is some of our own data. This is looking, because there wasn't a lot of data that I could find nationally about where people are going for STI care. So we looked at our entire hospital system, and we have a large tertiary care center. And so we see, you know, a large volume of patients. And we looked over almost 3 years, how many, where the STI tests were coming from in the hospital system. And the ED sent about 20% of the STI tests, which is already a pretty large proportion, but you can see about the same amount came from outpatient primary care. A big chunk came from OBGYN. But look here at where the positives came from. More than half of the positive STI tests came from the ED, despite the fact that we only sent 20% of the tests. So when people have symptoms, when people are, you know, concerned that they have STIs, we know that's where they're going. And then just to talk briefly about pregnant women. We know people are not accessing prenatal care, and a question came up in the Q&A earlier about, you know, whether these folks who are having congenital syphilis, maybe they were born in other countries, and so they didn't have access to care because of that. Well, they're not all. I don't know the numbers of how many are born in other countries versus born here, but I can tell you in you know, many parts of this country, regardless of where people are born, they're not accessing prenatal care. We know across the country, maybe 3/4 of patients receive adequate prenatal care. I would guess it's probably even less than that, but that was the published numbers I found. And you can see as well, you know, this is the young women, so non-elderly women living under 200% of the federal poverty level. 42% of them have Medicaid, and 19% are uninsured. And so you can imagine how difficult it is especially if you're in this uninsured category, to access care once you're pregnant. And we know that people are either not accessing any prenatal care or they're coming into the ED. National data shows that there's anywhere from 20 to 84% of pregnant women have at least one ED visit during pregnancy. And this is where, you know, this is where the issue with congenital syphilis comes in. This is a CDC chart showing, you know, where are these cases coming from? Well, this big chunk here, they had no timely prenatal care and were never tested. So, you know, while we ideally want every pregnant woman to have adequate prenatal care, we want to get them in early on, we want to get them tested at the OB office, we have to work within the reality of what is happening. And the reality is that people can't and don't access prenatal care, or if they do, it's often wildly insufficient. They come in late. So we have to find them earlier. And we know they're using the ED, and we actually looked back at our own ED, and this is hopefully soon going to be published as not published data yet. But we looked back at the women coming into our own ED in pregnancy to see what was happening to them. And so we looked over basically all of 2018 and looked back at everyone who had a positive pregnancy test. And then we checked the ones who ended up delivering at our hospital so that we could get some kind of, you know, more or less complete picture of what happened to them in terms of their prenatal care. And you can see the breakdown here. A large proportion of them had Medicaid and 13% of them uninsured. So kind of matches what you saw before. Although I will say this is data from that after their pregnancies. And so there may have been a larger percentage that started out uninsured and got on Medicaid by the end of their pregnancy. But what I think was really the kind of like very shocking thing for me, well, really not shocking because I kind of expected to find it, but I think from a public health standpoint, it's shocking. On average, these women were presenting to the ED at 9 weeks. Only less than a quarter of them had a prenatal appointment at that point, and less than half of them had any plan to access prenatal care. So had an appointment, could identify the name of an OB that they were planning to see. So less than half already at 9 weeks had any plan to access prenatal care. So we know that ED visit, we're already towards the end of that first trimester. That's our opportunity to diagnose people, to screen people. Who knows? A lot of them, in the end, a lot of them did end up accessing prenatal care, but it was highly variable. Some of them had 1 visit or 2 visits at some point in pregnancy. And a lot of them did come back to the ED during pregnancy. And so this was a huge opportunity, I think, really to get to reach that population that otherwise has really limited access to outpatient prenatal care. So why should the ED be a priority for syphilis screening? Hopefully I've already answered that question. The most vulnerable patients, the ones that we consider, that we see that those high rates of syphilis in, a lot of them are primarily coming to the ED for any of their healthcare needs, and they're not accessing outpatient care for a variety of reasons, most of which have to do with social determinants of health. And we know that a lot of times if they do access outpatient care, they're not screened. And so we really need to think about the fact that, the ED, it's where HIV, syphilis, other STIs, it's where people are coming with those. It's where they're accessing the medical system. So if we don't screen them there, it's a real missed opportunity. And I always like to point out that everybody has kind of bought into the fact that this model works for HIV screening. Everybody understands. No one walks into the ED or into for the most part, into any clinic appointment and says, oh, hey, I've been having, a lot of unprotected sex, I need to be screened. People don't like to talk about this. It's stigmatized. So we've all accepted that the way to really end the HIV epidemic is routine universal screening that destigmatizes it. It reaches everybody. And I argue, why is syphilis any different? We've seen the numbers going up. We know it has very high morbidity. We know routine screening works because the same issues that are going to make routine screening work for HIV, they work for syphilis. And syphilis screening, honestly, if you're already screening for HIV, it's easy. You build on that same infrastructure. And it really gets the screening to where the patients that should be screened are, which is in the emergency department. So I briefly want to just talk about what we did at the University of Chicago. So in 2019, we introduced this best practice advisory into our EMR. And essentially what it is it's routine HIV and syphilis screening for anybody who comes in under age 65 who hasn't been tested in the last year. And we put up these posters all over the ED to let everybody know this is what we were doing, just so that there would be no, questions. Everybody could kind of have this out in front of them. And what happened was this is the 7 months before and after we implemented this best practice advisory, we saw our syphilis testing numbers go up by more than 4 times. So we tested more than 9,000 people in those first 7 months. And you can see that the age distribution changed a little bit. We're starting to see a little bit of these older age groups, 35 to 44 and above, kind of increasing in number, which I think kind of reflects that we're seeing a little bit less bias in who's getting tested, which is overall a good thing. And here's what we found. We found that over that, this is actually over 9 months, the first 9 months, we found 163 confirmed untreated syphilis infections. So this is not just serology, but we also confirmed there was no past history of treatment. So these are true infections that needed treatment. So that was about 1.2% of our tested population, which is huge. It's a really large number. And I want to just point out a couple of other things about it. One is we looked at why they came into the ED, and we used ICD codes because that was the best we had, and realizing that ICD codes are an imperfect measure. But when we looked back at how many of them came in with anything that could even be, kind of vaguely construed as related to an STI, and that included abdominal pain, rashes, only 9% or so of them had anything like that. The rest of them completely unrelated to anything that could have potentially been considered an STI symptom. So we know that the people that we're finding with our universal screening, they're not people coming in for STI testing. And the other thing I want to point out is how many women we found in our sample. This is the CDC chart at the time of this data. So this is from 2019 of the percent of women nationally diagnosed with syphilis. And at the time, only 16.7% of the syphilis diagnoses in the US were women. And in our sample, it was 33%. So we had twice the rate among women as was reported nationally. And I truly, truly believe this is not because all the women in our population have syphilis more than anywhere else. I really think that this reflects the fact that we are all of a sudden screening everyone. And when you screen everyone, you find infections that you miss when you're using biases or, targeted guidelines that are based on old data about who's at risk. And so we're finding women. And we're finding young women, and these are the people that we need to be finding if we want to end a congenital syphilis epidemic. And we did see that our rates of syphilis went up during COVID, not just our percentages. We went up to as high as 2.5% positivity at the beginning of COVID. But we also saw, I don't have the numbers here, but we also saw an increase in the absolute numbers of people testing positive. So it wasn't just that we were testing fewer people and having more positives. It was also that more people were testing positive. But something else really interesting that I want to point out happened, which is that during the beginning and those early times of COVID, we saw our rate among young women, so women ages 18 to 24, they increased from 9.3% of the cases to 31% of the cases. So in those very early stages, when everything was shut down, people were doing tele OB care. We're seeing all of a sudden this huge rise in our cases among young women. And so, and I'm sure the same kind of thing was going on around the country. And here we are seeing these huge increases in congenital syphilis, and this is why. And these people were still coming to the ED, and we still were screening them, and we still were able to find them and link them to care. So again, this really was a key location for screening. And I should point out that on average over the past 4 years, we've had about 3 pregnant women screen positive per year through the ED routine screening for syphilis. And our linkage to care rates overall, the pregnant women we link, I think basically 100% of them to care. And overall, our linkage to care rates from the ED are somewhere between 70 and 80%. So really quite good. And we've been really, it's been a really successful program, and it's really, I think, reached a lot of folks. And I just very briefly want to mention, although we're not talking about HIV today, I'm sure all of you are interested in HIV and have thoughts about HIV. So I want to talk about how we've used this for HIV prevention. And there's been a lot of thought put into how do we find folks in the ED who are appropriate for PrEP, for HIV prevention, for linkage to prevention care, to surveys. How are we going to kind of identify these folks? I think that syphilis screening is a great way to identify people. It doesn't create any extra work. You don't have to ask anybody questionnaires. You don't have to ask your ED staff to do anything. You're finding a population where more than 90% of them had no STI symptoms, so maybe you wouldn't have identified them otherwise. And so we looked back at the folks that tested positive for syphilis in our ED, and I just want to say we enrolled about 49 of them who tested positive for syphilis, and 48, I think, who tested negative. Gave them surveys to see if they had, what would sort of traditionally be considered behavioral risk factors, and then compared the ones who did. And of the ones who should have been on HIV prevention, who tested negative for syphilis, none of them started PrEP, despite our explaining it, encouraging it, giving them the option, offering them to bring them in to get on PrEP. But 11 or 22% of the ones who tested positive for syphilis did get on PrEP. And we looked at how they perceived their own risk. And you can see here that compared to the ones that didn't have syphilis, the ones who did have syphilis perceived their risk of getting HIV to be a little bit higher. And so we think maybe this could be also a really useful way of identifying candidates. Not only do you have earlier diagnosis of syphilis, but also identifying candidates for HIV prevention and successfully linking them to prevention. So I know I'm out of time, but this is the summary of what I hope you will all take home from today, which is that EDs are a key location for syphilis screening. We will never succeed in ending the syphilis epidemic if we don't involve the emergency department. That's where patients are, especially those who have limited access to outpatient care. And universal screening in the ED is feasible, and it reaches the people that we're trying to reach. And there is more research needed to determine the optimal models for screening, and to create policy to support this in EDs throughout the country. But I think this is really something that I hope you all will take back to where you work and encourage in your own locations. Thank you so much.
Thank you so much, Dr. Stanford. Another great presentation. I just want to thank all of our presenters today for doing such a great job. And I think all of us have learned a tremendous amount from you. We have a little bit of time, and I will add one note that a recording of this presentation will be on the avac.org website later this week, along with slides. And with this, I will pose a question to our panelists, our speakers today, and really thinking about how do we get more people engaged in addressing the syphilis epidemic? How do we get people to start screening programs or testing programs within EDs? How do we really get people on board so that we can prevent some of these cases?
Well, I will start. I think Houston did a great example of how perhaps to send out notices through the state board making people aware that this is happening, and to reinforce the need to frequent screening in people at risk, but pregnant people specifically, reinforcing that this is a problem and we need to be very diligent in doing the correct screening and checking the results.
I think utilizing the EHR is huge because it takes the thinking out of the game. And it's just, if you have a yellow or a red stop that says order your syphilis screen, then obviously education, because we need a lot of that.
Yeah, I mean, I agree with what's been said. I think data is really, first of all, getting the education out there, but then getting data out, getting numbers out, showing that these models work, showing how we can do something about it, and showing what the impacts of the untreated disease are and the impacts of the screening programs are, I think will help. We really need to really get this to work, you need really a multidisciplinary team. You need the people who are doing the diagnosing, which means everybody in every setting, right? And then you need somebody to do the linkage to care, and you need the health departments to collaborate, and you need someone to get these folks into a clinic appointment to treat them. And so creating that team-based model that really bridges several disciplines is so key. And we have to kind of get the education out to all of those different groups so that everyone is enthusiastic about working together to solve this problem.
And with that, we are right at time. So thank you again to all of our presenters. I really appreciated your presentation so much, and I see so many great comments in our chat. Again, for everyone here today, this presentation, the slides, all the contact information will be available on the AVAC website later this week, and we will also send an email out with this information as well. So thank you, and I hope you guys have a great rest of your days.
Yeah.
Thank you, everyone.
Thank you.